So thank you everybody for joining tonight. This is our second pathology isolation shoot for Radiopedia. My name is Dr Natalie Yang and I'm the Medical Director of the Radiology Department at the Austin Hospital here in Melbourne, Australia. I'm also a pathology examiner for the College of Radiologists here in Australia, and this is, as I said, my second tutorial in pathology. So thank you to all the people who gave some feedback on the last session. We're doing it again, and if you enjoy it, then please let us know and we will do a third. So just to recap, my purpose for these tutorials is to inspire you all to think deeply about your pathology and how to apply this important knowledge to your radiology. Because as I say all the time, radiologists are pathologists, we just have a different type of microscope. And the very best radiologists understand this concept. But before we get started, I wanted to share this with the group tonight. So for those of you who don't know, Michael Leunig is a well-known Australian cartoonist and writer, amongst other things. And I find his work really interesting, and his take on things is at once both funny, mystical, whimsical, and sometimes just strangely weird. But you know, we are very, very fortunate in Australia to be contemplating the possibility of COVID-19 elimination, which I know not everyone around the world has the same luxury that we have here in Australia. But it has come with difficulties for everybody. Lockdown has been really hard, not being able to be with family and friends. And as Mother's Day had just passed, I'm sure there are lots of people there who miss their mum. And we need to think about that as well. We also need to think about our colleagues overseas who are doing it really tough. And we hope that these little tutorials are just a way for us to share and indicate to each other that we're thinking about each other and trying to support each other through these difficult times. What I like about this little one is life is hard, and we're in a time of uncertainty, and which is very anxiety provoking. But, you know, that's life. And we have to keep an open mind. There's always opportunity if you look for it, and it's what makes life interesting. So anyway, that's my 2 cents worth for the day. So let's get started. So just a recap of how I think you should approach your pathology study. I think you should look at it from two perspectives. You should consider how does the pathology affect what I see and interpret as a radiologist. But I think it's also important that you become the person in the room who has the most breadth and depth of understanding of whatever disease process is in front of you. This is what will make you valuable and the person that clinicians seek out for advice. And this is kind of the principle that I try to live by when I work day to day. So this framework around how to study your pathology is from the last tutorial, but I'm putting it up for review again. I think it's really important that whenever you study a condition, that you think about the structure on which you hang the information. This provides you guidance and understanding for the different disease processes that are available. So with that little introduction, we shall get started. Okay, so with that, let's get started on case number 1. So this is my specimen for discussion. Does anybody want to have a go at describing what they see here?
Yep, I'll have a crack.
Oh, terrific. Thanks, Mike.
So this is a cut specimen of a solid organ, which is wedge-shaped. And it's divided into lobes by fissures. So I think this represents the lung. And given that there is 3 lobes, I think it's the right lung, and perhaps a coronal section, the striking abnormality is multiple dilated tubular structures, which most likely represents dilated bronchi. These are present in the upper lobe and one of the lower zone lobes, possibly the lower lobe, with relative sparing of the remaining lobe. Mm-hmm. There's no scale there, but the dilated bronchi extend to the pleural surface, and just eyeballing it looks like they're at least 2 centimetres in diameter.
Yep, good.
The most severely affected lobe in the lower zone has volume loss. And I suppose given the distribution affecting two separate lobes, I'd be suspicious of an underlying systemic process. And I can't see any obstructing lesion or mass underlying. There is background changes of anthracosis, but no underlying lesion.
Wonderful. Great. That's a terrific description. So, yes, you are quite right. This is the lung. And yes, there isn't scale provided, but, you gave it a crack, and I think that's really important. And I think a lot of people don't try and understand scale when they're describing these pathology specimens. So I think it's really good to give that context. You said that it was coronal, but it's actually, do you want to revise that, Mike?
Might change it to sagittal, perhaps.
There we go. Beautiful. Yeah. So I think this is probably right middle lobe here, and I think this is right lower lobe here, coming down towards the costophrenic angle, and this is upper lobe. So quite rightly, this is bronchiectasis. Now, bronchiectasis in of itself is not a diagnosis, is it? It's sort of like the end stage of other processes. So with that, did you want to talk to me a little bit about bronchiectasis, Mike?
Yep, sure. So using the framework there, my understanding of bronchiectasis is that it is abnormal and permanent dilatation of the bronchi. And I suppose the epidemiology varies with respect to the underlying cause, of which there are several. So some of the causes, or more common causes, include cystic fibrosis, various infections, including childhood infection and TB. You can have other causes like primary ciliary dyskinesia, and then there's the obstructive causes, like where there's a central mass or foreign body resulting in distal obstruction.
Yep, good.
From a pathogenesis point of view, I understand there's a vicious cycle of recurrent obstruction and subsequent infection, or sometimes the infection can precede the obstruction. And once again, that would vary as to the underlying cause.
Okay. And can you describe the morphology?
Yep. So there's several different morphological subtypes. I'm just picturing CT in my head. You can have cylindrical bronchiectasis, cystic bronchiectasis, and varicose bronchiectasis.
Great.
Are the three kind of gross morphological subtypes.
Terrific.
Yep.
And complications?
So complications would include recurrent infection, hemoptysis, volume loss, and I suppose associated impaired respiratory function, and perhaps underlying fibrosis.
Yep.
Yep.
And how might patients present?
They could present with chronic productive cough, and potentially recurrent pneumonia or lower respiratory tract infection, or perhaps I suppose you can see clubbing with bronchiectasis.
Yep.
And hemoptysis is a known cause.
Great. Okay. So can everybody see how Mike's framed his discussion around these headings? And the real benefit of having the framework is being able to put your knowledge into a tree, if you like, and be able to answer the questions in a logical fashion and actually talk about diseases in a logical fashion. So that was terrific. Thank you, Mike. I appreciate that. So just to recap, the definition of bronchiectasis is a disorder characterized by destruction of smooth muscle and elastic tissue by chronic infection leading to permanent dilatation of bronchi and bronchioles. Okay, so that's the key features there are the destruction of the smooth muscle and elastic tissue, that it's permanent, and that it leads to this dilatation of bronchi and bronchioles. As Mike correctly identified, there are a number of underlying different causes for bronchiectasis, and you can sort of break them down into infectious causes or genetic type causes. So genetic would be cystic fibrosis. In the Australian population, that'd probably be a very common cause of early onset bronchiectasis within our demographic, but also primary ciliary dyskinesia is one of those other genetic type associated, and carcinoid syndrome is the other one that we think about in terms of congenital and hereditary. In terms of infection, bacteria, virus, fungi, don't forget aspergillus can be seen in association with bronchiectasis. So ABPA that we talked about last time is often seen with dilatation of the bronchi, and also of the atypical infections, mycobacteria, MAC. So atypical mycobacteria is one of the key features, is seeing that bronchiectasis, particularly in the right middle lobe. The very important thing as radiologists to be certain of is that if you see bronchiectasis identified within a lobe, as opposed to being widespread, then look really hard to make sure that there isn't an obstructive lesion at the apex of where that bronchiectasis is. That's a really key feature. So bronchiectasis on its in a lobar distribution without anywhere else seeing those kind of changes, really look really hard to see whether you can see something obstructing it. Now, with respect to the pathogenesis, I thought we would just break this down a little bit and go into a little bit more detail. And it turns out that I'm a terrible drawer, but I'm an even worse drawer when it comes to doing things on the computer. So please don't laugh too much at my terrible pictures here, but you kind of get the idea. I have many talents, but drawing is not one of them. So here we have what looks like a happy normal bronchus, and Frank looked at it and said, "Oh, is that the aorta?" I said, "No." He goes, "But it's orange." I go, "Yeah, whatever." Anyway, this is meant to be a bronchus, and what we're going to show here is what happens when we get infection. So typically there's obstruction of the bronchus for whatever reason, and this then leads to a pooling of secretions distal to the obstruction. And whenever there is stasis, like stasis is the basis of infection, right? So whenever you get stasis of columns of fluid, you then get the risk of added infection. So this is within the fluid that's trapped within the bronchus. And the typical agents that will cause infection of this sort of fluid will be your staphylococcus, your streptococcus, your pneumococci, enteric organisms, anaerobic and microaerophilic bacteria. And in children, it's Haemophilus influenzae and Pseudomonas aeruginosa that infect this fluid which is trapped. Now we're going to go from blue fluid to green fluid because now it's infected and disgusting, right? And then from here, what we then see, if we then take an image of the wall of the bronchus, so there's infection within the mucus that's been stuck, and then what now happens is that infection then translates into the wall of the bronchus, right? So here we have, and again, apologies for the crappy picture, we have mucus, which is the green stuff here. We have our epithelium with its little cilia. We've got our little mucus gland, which is producing some of the mucus. And then here we have the smooth muscle with the little vessels in between. So what happens when the infection occurs, we get an influx of acute and chronic inflammatory exudate into the wall of the bronchus, all right? So whereas initially we had stasis of the fluid, it becomes infected with all these organisms, now we're shifting into the wall of the bronchus. And this is the key thing about the pathogenesis for bronchiectasis. Not only do we get inflammation within the wall, we start to see desquamation of the epithelium with areas of ulceration, and we may even see pseudostratification of the columnar cells or squamous metaplasia of the remaining epithelium. Okay, so from there, the wall breaks down and we get the formation of a little lung abscess, because now the wall is no longer acting as a barrier. So we're now getting that disgusting infected goop extending into the adjacent lung parenchyma and the formation of a lung abscess. And this process over time, with the ongoing destruction of the smooth muscle and elastic tissue of the bronchi, results in them becoming permanently dilated. And these are the classical radiological patterns that Mike correctly identified. So cylindrical, cystic, varicose. with the caveat that the smaller bronchioles actually become progressively obliterated, because in addition to all these processes, there is fibrosis as well. Okay, so this is now a perfect opportunity for us to talk about using bronchiectasis to review some basic fundamental pathology principles and about inflammation. So we've talked about the fact that inflammation is important in the process for subsequent tissue destruction in the context of bronchiectasis. So let's now take this opportunity to review inflammation itself. Now, as I said last week, a lot of people ask me, can I just get the first 10 chapters of Robbins and just get to the last, 20 or whatever it is? And I will always say no, because I think that these 10 chapters are extraordinarily important. To me, the first 10 chapters of Robbins basically forms the building blocks for your understanding of pathological processes later. So if it's a little bit like not learning your alphabet before writing the life-changing novel. You've got to do it. And it's not fun, but it actually underpins all of your understanding for pathology. So really going hard, and there's some key chapters there that I think are really important for every radiologist to understand. So with that, who would like to talk inflammation with me?
I will.
Oh, thank you, Elmo. All right, so tell me, what is inflammation?
So inflammation is a response by tissues that are vascularized, and it's usually in response to harmful stimuli such as infection or a toxin, and the purpose of it is to eliminate that harmful stimuli and to initiate repair to return that tissue back to normal.
Beautiful. That's lovely. So can everybody see what's on the screen there? So what is inflammation? It is the response of vascularized tissues, as Elmo has correctly identified, to infection and damaged tissues that brings cells and molecules of host defense from the circulation to the sites where they are needed most to eliminate the offending agent. So it's that shift from within the circulation into the interstitium that is one of the key features of inflammation. And what follows on from that is that it can only happen in vascularized tissues because you need a blood supply to be able to do that. So that's a great definition. Thank you, Elmo. So do you know about the series of steps that one might see in inflammation?
So in Robbins, they summarize it as the 5 R's.
Mm-hmm.
So the first R is recognition, or recognizing the injuring or the injurious stimulant. And then once it's been recognized, the second R is recruitment. So you've got to recruit the leukocytes to the area. And then once the leukocytes have been recruited, then they remove the infectious or the injuring stimulus. Mm-hmm. And then the fourth R is regulation or control of the response, so it doesn't go out of hand. And finally, once the stimulus has been removed, then there's resolution or repair.
Beautiful. Right. So I hadn't heard of 5 R's, but you must be reading a different version of Robbins to me, but that's fine. But absolutely what you said. So it's recognizing the offending agent, recruitment of the appropriate inflammatory cells to the injured site, activation of the cells. So cells will have different stages of activation, and that's what initiates some of this inflammatory response. And it's not just about the cells, it's about the proteins as well. And the aim of this cascade is to destroy or eliminate the offending agent. You have to control the reaction, and if you don't control the reaction, that's where you start leading into some problems, and we'll talk about that in a second. And of course, the final stage is, of course, repair of the damaged tissues. Elmo, do you know of any conditions that is associated with inflammation being the underpinning problem of the disease process?
So autoimmune disorders, infection, even I think there are some conditions such as atherosclerosis that they now think is actually inflammatory in nature.
Yep, good. Yeah. So I've got on the screen there, I don't know if you can see that, Elmo. Can you see this table in front of? Yeah, beautiful. Right. So here are some examples of where inflammation actually is part of the problem. So acute respiratory distress syndrome, asthma with overactivated eosinophils, atherosclerosis, as you correctly identified. You know, the inflammatory response is part of the problem as to why atherosclerosis develops, and the same is with arthritis. And this septic shock here, so the cytokine. So a more contemporary illustration of the disastrous effects of an overreaction of the inflammatory pathway is what happens in COVID and flu with cytokine storm. So cytokines, as you all know, are the small proteins that are released by all the different cells in the body to coordinate the body's response against infection and to trigger an inflammatory cascade. But for some patients, and we're not certain why, the immune response is so pronounced that it leads to these really uncontrolled levels of cytokine release. And the concept of cytokine storm is not something that's unique to COVID-19. It's seen in other coronaviruses such as SARS and MERS, but it's also seen in non-infectious disease processes such as MS, pancreatitis, and certain drug reactions. So it's important to understand that inflammation is there to help our bodies, but it can also be there as the underlying cause and driver of disease processes. So tell me, Elmo, what are the key differences between acute and chronic inflammation?
So acute inflammation is a more short-term response, so typically hours to days. And the key components of acute inflammation is firstly, you get a vascular response. So you get vasodilation and the endothelium of the vessels becomes leaky so that you can get leukocytes or white cells migrating to the area of injury. And the main leukocytes in the acute inflammatory response are neutrophils. In contrast, chronic inflammation is a more prolonged response, so typically seen over weeks to months. And the key components of chronic inflammation, it's a combination of inflammation. You also get injury to the tissues, and you also get attempts at repair, and all these processes are all happening at the same time in chronic inflammation. And as opposed to acute inflammation, the main cells are typically monocytes and macrophages as opposed to neutrophils.
Beautiful, great. So that's a beautiful description. So I've got, I love tables. God, I can already see a typo. Anyway, we'll worry about that later. I love tables to try and really highlight the comparisons and the differences between the two processes, and you beautifully summed it up. So just starting with acute inflammation, it's a rapid process, as you correctly identified, and it occurs within minutes to hours. As you say, there are three key responses within acute inflammation: dilatation of the small vessels, increased permeability to allow plasma cells and cells to accumulate in the interstitium, and migration of those leukocytes from the microcirculation with activation of the leukocytes. And the dominant cellular infiltrate is neutrophils. This is important because it underpins the body's ability to shift fluid and plasma proteins or cells from the intravascular space to the interstitium or body cavity, which is often the site of where the injurious agent is located. By comparison, chronic inflammation is as you say, chronic process, and it can result from acute inflammation that doesn't get resolved, or it can occur de novo with sort of a low-grade, grumbling, smouldering response and manifestation of without any manifestation of a preceding acute inflammatory response. By contrast, there are coexistent three things going on. So you've got inflammation, tissue injury, and repair all happening at the same time. And to assist this process, there needs to be proliferation of vessels. So you see angiogenesis in chronic inflammation, as well as deposition of connective tissue. Fibrosis is a very important feature of chronic inflammation, and the cell infiltrates, the dominant cell infiltrates are your monocytes and your macrophages or your lymphocytes. So that these are kind of the two characteristics between acute and chronic inflammation. Can you tell me anything about granulomatous inflammation, Elmo?
Yep, so granulomatous inflammation is a form of chronic inflammation, and it typically occurs when the inciting stimulus is very difficult to remove. So, for example, if there's a foreign body or a difficult microbe such as Mycobacterium tuberculosis or TB, which is difficult for the macrophages to phagocytose and eliminate. And the key cells in granulomatous inflammation, as it's a chronic inflammatory process, it's mainly macrophages. And I think pathologically they can aggregate and form a granuloma. And then there are two types of granulomas. There's the necrotizing, which is typically seen with infections such as TB, and then there are non-necrotizing granulomas, which are seen in other processes such as sarcoidosis.
Fantastic. All right. So that's a beautiful description. So yes, absolutely. So granulomatous inflammation is a particular form of chronic inflammation. And as you correctly identified, it's macrophages that are activated, but it's actually T cells that activate the macrophages. Okay. So there's a strong T lymphocyte response, which then leads to macrophage activation. And these activated macrophages look like epithelial cells. So they can be called epithelioid cells. So they look like epithelial cells, but they're not, they're macrophages. And then when these epithelioid cells fuse together, they form the multinucleate giant cells that we talk about. And there are two types of granulomas. There's the ones associated with foreign body granulomas, and there's the ones that are associated with immune responses, of which TB is the sort of the classic example of a granulomatous infection. And we will talk about it, but not tonight. So you'll have to tune into next time. Thank you for that description about inflammation, and I hope that what you've seen there is an illustration of how going back to first principles and understanding those basic building blocks is really important to informing the way you understand your disease processes as per systems-based. So just coming back to the discussion about bronchiectasis now, I really wanted to touch on the cause. And Mike, you talked about post-obstruction being one of the causes of bronchiectasis. And I highlighted the fact that if you see focal bronchiectasis, you need to look really, really hard for that obstructing lesion at the top of it. So do you want to tell me about some of the, do you know of what particular type of tumour is classically described in this context?
So like an endobronchial tumour would be one to cause obstruction.
Yep, good. And what kind of endobronchial tumours do you know?
So you could have a SCC, for example, central SCC with distal obstruction, or carcinoid tumour.
Okay, beautiful. Good. All right. So did you want to describe this specimen to me in that context then?
Yep. So this is a cut specimen of the lung, which demonstrates a rounded, predominantly pale lesion with hemorrhagic foci peripherally. And adjacent to this, there are several dilated tubular structures, which in this context most likely represent bronchiectasis. And on the left-hand slice, there is an area at the upper aspect of more red and presumably hemorrhagic region within the lung.
Wonderful. So what do you think this most likely is?
So given the rounded appearance and quite regular, perhaps favour a carcinoid over an alternative endobronchial lesion.
Beautiful. All right. Off you go. Tell me about bronchial carcinoid.
So bronchial carcinoid is a neuroendocrine tumour, and it arises from the Kolchitsky cells.
Nice.
Can be seen in other areas of the body in addition to the lungs. In terms of epidemiology, my understanding is that it's seen in slightly younger patients compared to other types of pulmonary neoplasms. in it's more middle age as opposed to elderly. And there's an association with some conditions such as multiple endocrine neoplasia.
Yep.
Can't specifically remember if there's an association with smoking, but it wouldn't surprise me.
It's actually so 20 to 40% are non-smokers, so that means that 60 to 80% are.
Right, okay. When in doubt, smoking is a risk factor.
Yeah, that's not a bad principle to live by. Can you tell me much about the pathology?
Aside from the fact they arise from the cells of Kulczycki, I can't remember. I do remember there's a spectrum of disease, and that you can have low grade, and then it's divided into typical and atypical.
Very good.
Typical tends to be have a better prognosis.
Very good.
Compared to atypical, which is more likely to be invasive and has worse outcomes.
Fantastic. Yes. So typical. So the characteristic histologically is that the typical has a lower mitotic rate with no necrosis, whereas atypical has a higher mitotic rate with foci of necrosis. So that's right. So they tend to be low grade. They can be classified into typical and atypical, and typical has a better prognosis than atypical. Excellent. And do you know how these patients might present?
Because they're endobronchial, they can present with wheeze or cough, or a result of distal obstruction. And I think that's typical for the central lesions, but peripheral lesions can be incidental findings because they're less likely to cause those symptoms.
Terrific. And what do you know about carcinoid syndrome and carcinoid heart disease?
Carcinoid syndrome, I remember you can see with any kind of carcinoid malignancy, and it occurs in a minority of patients with bronchial carcinoid, and you get a syndrome of diarrhea, flushing, and maybe bronchospasm, and it's a result of release of certain vasoactive and neuroendocrine substances from the lesion itself.
Terrific. And carcinoid heart disease?
My vague understanding is that you get some kind of cardiomyopathy and heart failure for similar reasons.
So in the heart, they get on the endocardial surfaces, they get development of these sort of intimal plaque-like deposits, which are composed of smooth muscle and mucopolysaccharides, and it's seen in about half of the patients who present with carcinoid syndrome. There's also an association with tricuspid regurgitation and pulmonary stenosis. But yeah, fantastic. Okay, so with that, we'll move on to case 2, and let's have a look. Who would like to have a go at describing this case?
I suppose if no one else will, I will.
Thank you, Benjamin. Hi, Ben.
Okay. So we've got a gross specimen of looks like a multi-cavity organ. We've got at least a single cavity that we're looking at closest to us has quite thin-walled, and then a further cavity deeper which appears to have more thickened wall. That is probably reddish in colour with a little bit of yellow tinge, probably demonstrating a bit of blood-stained fat externally with thickened muscle wall is what I'd assume that is. There's a further cavity laterally on the left-hand side, or my left, which is partially visualised. So I've got multiple cavities. Deep within the larger cavity, there's some irregular folds, and of course this pathology centred from the middle of it, which is almost bubbly in appearance, quite deep, rich, and quite vascular and blood-stained, almost as like a projection or a growth arising from that medial aspect. Difficult.
So where are you?
I'd favour this to be the heart. I think it's a multi-chambered organ with some muscle and fat. There's just the problem is I can't see any discrete valve or papillae or any draining sinus or anything to really just sell it. But I think that's what we're looking at. So I think we're looking at the heart.
Okay.
With that in mind, so this I'd favour this to be. This is not the appearance I'd see of a semilunar valve. This looks more like a atrioventricular valve because it's quite wide and there's no those sharp demarcated cusps. So I think this is probably most likely left-sided heart, and that's sort of that growth. It looks pedicled on probably the annular ring or where I'd expect the valve to be. It's almost replacing the valve.
Okay.
So my differentials for an intracardiac mass lesion includes both pseudotumor and true tumors. Pseudotumors being thrombus, rupture, and infection, and whereas the more neoplastic processes would be, there's tumors proper would be neoplastic or non-neoplastic. Of the neoplastic, they'd either be primary or secondary to the heart.
Okay. I'll just stop you there for a second. That's a great description. And I think exactly the principle that we talked about on the first tutorial is always be certain about where you are in the body before you start giving a differential, because you'll either get it blazingly correct or blazingly wrong. So I think this is actually a very difficult specimen, and I think it is hard. And I think in the exam, as long as you had a reasonable approach to trying to work out the organ of origin, you will find that the examiners will tend to help you once you've given it a fair go. So I think what you did there was a great approach, was to really take a step back and go, right, so I'm dealing with you could say a hollow viscus or an organ with some cavities, as you described. And I think the observation that there's some muscle component versus areas that have no muscle is a fair place to start. If it wasn't the heart, Ben, what might this be?
Yeah, I suppose it could be. Well, it could be bowel, but again, I wouldn't like the discrepancy. Wouldn't be. It could be bowel, could be colon, and they could be haustra, and that could be colon cancer, etc. And they could be is the other thing. It was just too muscular on the thicker wall that just sort of
led
threw
you
it
that
against
way.
me.
No, that's fair. But I think it's good to just contemplate in your head, because in your exam you might not, it's always good to try and have a list of things to try and help guide your discussion, right? So if you said to me this was liver, well, I'd be like, oh, I'm not helping this guy because, he needs to start again. Whereas you've identified correctly that, this is a hollow structure that we're dealing with. So give me a list of hollow structures from which this lesion could originate from. And then you correctly identified the fact that you need to understand the relationship of this lesion to the valves, assuming that this is heart. And that's a really good approach. Are we dealing with a valvular process, which we are not in this instance? And I think it's really hard on the basis of this image here to really understand that. But in the heart, you need to understand which layer are we dealing with. And so you correctly identified that this is a mass, and then you were going to go on and talk to me about cardiac tumors, and you were going to go down the line of primary and malignant, or primary and metastasis. Was that where you were headed?
That's correct. Yeah, I think that's how I delineate it. Yeah.
Good. All right. So tell me about cardiac tumours before I interrupted you there.
So the classification I have is you've got non-neoplastic as well as neoplastic. So non-neoplastic being hematomatous lesions, thrombi, tumor, infection, which we've discussed. Mm-hmm. The neoplastic we divide into secondaries, which is the metastasis from other organs or other sites, and then you've got primary cardiac tumours.
And which is more common?
Secondaries by far, yeah.
Do you have a ratio in your head?
About 20 to 40 times. Very, very much so. So primary cardiac tumours are extremely rare.
Mm-hmm. And in the metastatic group, what are they coming from? What's the most common metastases?
I think the most commons, if you include the pericardium, around the heart as part of the heart, then I think the most common is mesothelioma, direct extension from mesothelioma and lung cancer are the two big ones from a direct extension. But I suppose any tumour that has the ability to do hematological or lymphatic seeding could actually end up in the heart. The common ones are common, so lung right up there, breast right up there, renal, ovarian has a proclivity for the heart, as well as melanoma, which is the cancer that just can go anywhere and everywhere in the weird and wonderful places, and the heart's one of those. And you always have to include lymphoma in your differential of secondary metastasis.
And what about primary?
So primary, it's harder because you'd like to know where it's arising from. Really helps you guide that. But I suppose just as far as, without looking at this lesion, just classifications in general, you've got benign or malignant. The benign ones, the most common tumour is a myxoma, a cardiac myxoma, but that's typically more atrial, and I wasn't quite confident that this was atrial in origin, but the other ones, just the lipoma is very common, but they're typically more intramuscular rather than this one, which I think is favoured to be more endocardial lining. And there's a weird one, a papillary fibroelastomas. They're probably the next common. They're the big three from an adult point of view from a primary. And then if this was a child's heart, which I don't think it is. Oh, excellent. Yes, excellent. This is what I needed.
This is what you needed.
Very good. What did I miss? A fibroma, that's children's, and a rhabdomyoma, that's tumours. And angiosarcoma is malignant. So all the others we've alluded to as benign. So angiosarcoma, I'd have it on a different thing there. But they'd be the most common malignant primary cardiac tumour.
By far and away, it's these top five which are the most common, and angiosarcoma is really, really rare. So with that, can you talk to me about cardiac myxomas? So that was a case of a myxoma. But can you talk to me about what you know about cardiac myxomas?
So cardiac myxomas, as we've already discussed, a benign primary neoplastic lesion of the heart. It's mesenchymal of origin. I think it arises from the endocardial layer. Epidemiology-wise, it's in the older population, so not children, 40 plus. The associations, there is a complex, I think the Carney, it's either the triad or the complex. I think it's the Carney complex in this occasion, CCC, complex cardiac, So that's its main associations. And I think it has a weak association with fibrous dysplasia, the McCune-Albright syndrome as well.
Okay.
From
I think MEN is the other association. MEN, for cardiac myxomas. Yep. All right. So what do you know about the pathology?
So macroscopically, well, if we go back to the last slide, we can see what this one looked like. But I think cardiac myxomas have quite a varied appearance. So they're not just, but I suppose typically they're more well circumscribed, arising from the atrial septa, typically the left, in the left atrium, more so than the right. And it can be, and they're quickly quite large, but again, they're varied appearance. They can be from quite solid and firm to more myxoid and mucinous and gelatinous. Yeah, that's right. So to be a very, very, very varied appearance in their macroscopic appearance, morphologically, microscopically, it's also quite a heterogeneous lesion. We've already alluded to the fact that it's cystic and it's got that sort of myxoid type appearance, but also it can have hemorrhage
and how might they
some
present?
connective tissue fibrosis and. So often they're incidental. They can be picked up by our fancy imaging if you look close enough.
If you look close enough, that's right.
But I suppose if they were to cause symptoms, it depends where they grew from. The most commonly is the left atrium, so it can cause obstruction is the main one, especially if it's pedunculated, and so it can cause obstruction, which causes congenital heart failure, pulmonary hypertension, sudden cardiac death as well. It can prevent nice blood flow, and it can flick off emboli. So there's a whole host of secondary causes, but the main one's probably incidental finding.
Okay, wonderful. Okay, so I just wanted to flick back a second to go back to this metastatic category, and just something that I was reading, which I think is really important for everyone to take home, is that cardiac, according to the literature, cardiac mets are in patients with a known primary is something of the order of 9%. So if I think about the number of times I'm sitting out at repat, which is where we do all our oncology staging, and I read all those, staging for all these cancers, I am not picking up cardiac mets at a rate of 9%, and I doubt any one of you are either. So it's either that it's really subtle and we don't see it on imaging, or, which I think is probably more likely the case, is that the heart is a big black hole to most radiologists. It's not the big black hole, it's the big white hole in the middle of the post-contrast CT for the majority of radiologists. And what I really want to encourage you all to do is really look. We need to look. We can't avoid looking at the heart anymore. It's time to take ownership of this organ. So it was just an interesting fact for me as I was reading through stuff that, cardiac mets are present in up to 10% of patients with cancer. I certainly do not report it at that rate. So it's just something to keep an eye on and think about as we move forward. All right, Ben. So I might get you to, by comparison, just describe this one for me.
So this one's more obviously a cut specimen of the heart. It's cut through the atria and ventricle and splayed out. The thickness of the ventricle wall, I think they're markings down below. So I've got that as at least above 2 centimetres. Is that correct, or have I misread that labelling? So, so the background heart itself has a hypertrophied heart. It has, but no infarct or scarring. The abnormality here is these warty-like projections that have exophytically grown from the atrioventricular valve in this case, and also spread to the chordae tendineae. I don't see any moderator band, so I'm going to favour this to be the left heart. So we'll say, left warty projections on the valve.
Which valve?
Mitral valve, sorry. Yep.
Mitral valve. And so what's your diagnosis?
So I'd favour this to be, this is pretty classical for infective endocarditis.
Okay. Acute or subacute?
So mitral valve, there doesn't seem to be too much destruction. No, I'd probably say acute. I don't think there is a bit of destruction. There's some hemorrhage and fibrosis. Yep. Okay.
So tell me, how do you know that this is not, sorry, apparently my mouse doesn't work, but the white portions on the superior aspect of the image.
Your white mouse is working.
My mouse is working now? Okay. So this portion up here on the superior portion of the image, you said that was atrium, and you're correct. How do you know it's not aorta?
Good question.
I only asked you questions.
Well, I suppose from the whole specimen, we've got the papillary muscles, we've got and chordae tendineae, which the aortic valve doesn't have.
Okay, all right. So this is a trick for the exams. Okay, when you get the heart, the first thing to try and identify when you get it splayed open like this is: am I dealing with mitral valve or am I dealing with aortic valve? And there's a beautiful diagram on the internet, but I couldn't copy it. I couldn't use it because of copyright issues. So I've drawn it. So apologies. And Frank, oh no, hold on. This is not working now. Just hold on, guys. Sorry, Frank. I'm just going to. It's been a bit flaky tonight. Here we go. Can you guys see that?
Yeah, that's good.
Yeah. Can you see the diagram?
Yep.
And we've gone back to the picture. All right. So just hold on. I'm just going to restart here. So there's an excellent diagram on the internet which shows this beautifully, but I couldn't reuse it because of copyright issues. So I've gone and drawn it. So apologies. And when Frank took a look at it, he sort of rude things came into his head, of course. So please take this diagram with a grain of salt. But what the key thing for identifying the aortic root is identifying that you've got the left ventricle, so you've got your thick muscle like what you did just then, and both the mitral valve and the aortic valve are tricuspid valves, right? But the thing that's different in the aortic root when it's splayed open is there's this ridge that occurs just above the aortic valve called the sinotubular junction, and it's this really subtle ridge that goes across. And then as you drop down below that, you see the cusps, the three cusps of the aorta, and you should see the origin of the coronary arteries arising in the left cusp and the right cusp, with the third cusp, which is the non-coronary cusp, having no coronary artery. So that's the clue. If you see a little hole on the specimen in that white portion and you see two of them side by side intimately related to the valve, then you know that you're dealing with the aortic root and the aorta. And that's the key difference between that and the atrium. And that's a little trick that a lot of it can help you in the exams. So just to try and orientate yourselves. So with that, I'm going to hand over to somebody else. So thank you, Ben, for doing such a great job. We'll just get you to go onto mute there. Would anyone like to talk about infective endocarditis for me?
Yeah, I can give that a go.
Okay, is that Tim?
Yeah.
Excellent, Terrific. Off you go.
So in terms of definition, as we can infer from the name, so infective endocarditis, so there's going to be an infection. So you typically have a microbial infection of either the cardiac valves, which was keeping with that image we saw, or the mural endocardium itself. And that microbial infection can lead to vegetations and associated damage and destruction. So that's what infective endocarditis is. Mm-hmm. And then in terms of epidemiology and risk factors, I'm not aware of kind of a geographic predisposition across the globe or any ethnicity differences with respect to infective endocarditis. But in keeping with its pathogenesis, there would be some risk factors for it. So if you're somebody who has a prosthetic valve, you might be at increased risk, or if you're somebody who's had prior damage to a valve. So infective endocarditis can affect both normal valves and damaged valves. So if you've had rheumatic heart disease, or if you've had calcific stenosis, or if you've got a congenital, bicuspid valve, that can predispose you to infective endocarditis. And then also with risk factors, so if you're going to expose yourself to organisms, so if you're an IBDU or if you have a dental procedure, so in terms of epidemiology, again, not necessarily an ethnicity or geographic distribution, more if you have issues with your heart, your valves, or you're exposing yourself to microbes. Mm-hmm. So that's what I would have as risk factors.
Yep, and classification?
And so classification can be done clinically. So if you're somebody, so it can be kind of an acute storming course of acute infective endocarditis or a subacute course. Mm-hmm. And the acute is more a couple of days, maybe weeks, whereas the subacute is going to be weeks to months in duration.
And what other key differences are there between the acute and subacute classification? So you said the onset of disease. What else?
In terms of how they present, so somebody who's has acute infective endocarditis, they will look basically like somebody who's septic. So rigoring, fevers, very unwell, unless they're very old. If they're in the elderly population, they may not present with those symptoms. And then with subacute, it can be just more like a vague flu-like symptoms. So that can be their presentation.
So the key feature between the two is that it's the organisms. So acute infective endocarditis tends to have more virulent organisms such as Staph aureus or Staph epidermidis, and it typically occurs in otherwise normal valves. It can occur in deformed valves, but normal valves is usually what get involved. And there's a high risk of death within days to weeks because of the severe destruction of the valves. By comparison, subacute infective endocarditis, as you correctly identified, has a more insidious onset, and it's because the organism involved is less virulent, so typically a strep viridans. And typically, unlike in acute where it's normal valves which are involved, it tends to be those with pre-existing valvular abnormalities, and overall there's less destruction of the valve. So going back to Ben's picture, and I think it's really hard here, but given how big these vegetations are, the valves themselves aren't particularly destroyed. And so this is in fact a case of subacute infective endocarditis as opposed to acute. But I take the point that it's really hard in this specimen, but that's really the key difference between acute and subacute. So so I've already alluded to some of the organisms. Can you talk to me about any other organisms that you know that are involved in infective endocarditis?
Yeah, so if I mentioned the prosthetic valves earlier, and
Yep.
I think Staph epidermidis is an organism that can be associated with those. And then there's the Hakek group, and I can't remember all of them, but I think it's Haemophilus. There's Kingella in there and Eikenella in there, and then the A and the C.
Actinobacillus and Cardiobacterium.
Yeah.
Like you're ever going to remember that. That's okay.
and I think that overall Staph aureus is like 20%, and Strep viridans is about 50%.
Mm-hmm. And in 10% of cases, you don't find the organism at all. Yeah. Okay,
yeah.
Good. All right. And talk about the morphology. So what do these things look like?
So morphology. We're going to have microbes essentially in these vegetations that are kind of these big friable thrombotic vegetations. They've got microbes in them. They'll have acute inflammatory components. They'll have necrosis associated with it. And with, I think, the acute infective endocarditis, that process can extend and you can have abscesses, ring abscesses that are associated with it. And I think one of the differences between acute and subacute is because subacute takes longer, you might have, and elapses over a longer period of time, you might have less of that destruction, and you might have the opportunity for some granulation tissue to form, and that might be a difference between them.
And how do these patients present?
So I touched on it with the acute versus subacute, just how they look, somebody who's septic and rigoring versus somebody who's got vague flu-like. So that's how they can present, but they can also, because you've got these little vegetations, they can thromboembolize throughout the body. And so you can get, I don't know if we see them much anymore because of the treatment that we can for these patients, but if that goes to the hands, you can get the Janeway lesions and the Osler nodes, and then Roth spots in the eyes. If you went to the lungs, you'd get lots of septic emboli there potentially, and if it goes to the kidneys, you can get a glomerulonephritis as well.
And that's due to an antigen and antibody complex which deposits within the basement membranes. That's right. Terrific. Okay. So one of the key things, thanks for that, Tim. That was terrific. One of the key things that comes up in the exams is trying to tell the difference between all these valvular vegetations. And I think it's a really useful exercise to just go through the different types of valvular vegetations that we might see. So starting in the second column here, infective endocarditis is those large, irregular, friable masses, typically involving the valve. And in the acute setting, there's valvular destruction, and in the subacute setting, there's less marked valvular destruction. By comparison, rheumatic heart disease tends to have these very small, warty vegetations, which are located on the lines of closure of the valve leaflets. So where the valve leaflets touch each other, that's where you see these small, warty vegetations. And you do see a degree of fibrinoid necrosis of the valves associated with this. So, of course, rheumatic heart disease is a complex disease process that has an acute phase and a chronic phase. And in the acute phase, you see pancarditis, with the key cells being the Aschoff bodies and the Enitzgau cells, which I'm I'm sure I'm completely saying that incorrectly. Whereas in chronic rheumatic heart disease, you get thickening of the mitral valves and commissurial fusion and thickening tendinous cords. By comparison, the non-bacterial thrombotic endocarditis, and this is also known as merantic disease, are these small, bland vegetation, so they're sterile, unlike infective endocarditis. And again, these ones, like in rheumatic heart disease, attach at the lines of closure, but these are not associated with any valvular destruction. And the thing about these vegetations that they're associated with cancer, in particular mucinous adenocarcinoma, but they're also associated with sepsis and trauma, and they can result in DVTs, and they can embolize distally, and they have an association with DVTs and PEs and migratory thrombophlebitis. And then the last sort of group of vegetations are the so-called Liebman-Sachs endocarditis, which are associated with SLE. And these are small to medium-sized vegetations which can occur on either side of the cusp, or either side of the valve. And when what you see is that the valve itself is very inflamed, and you may see a degree of fibrinoid necrosis. So I think that's just a summary of the different types of valvular lesions or vegetations that you might see, and how to try and distinguish between the two. And being able to talk around this, I think, is really important for the purposes of your knowledge, but also for the purposes of the exams, for those of you who are coming up to oral exams later this year. Thanks for that, Ben and Tim. That was terrific. So what we'll do now is we'll move on to case 3. So would anyone like to have a go at describing this for me?
So this is a macroscopic cut specimen of what appears to be a tubular hollow viscus. There's also a central hemorrhagic ulcer with no obvious perforation. And it also looks like there's multiple small kind of polypoid lesions to the left of that ulceration. And the bowel wall itself is a bit hard to see in some sections, but it doesn't appear to be any obvious thickening or true irregularity of the different areas of the bowel wall that I can see. What I'm trying to decide is what part of the gastrointestinal tract this could be. So I'm trying to see if there's any rugae or valvular convergentes or any haustra.
Yep, good. So it's hard in this specimen because the underlying process has destroyed all of those normal anatomical landmarks to help you. So I'll help you here. So we're talking about the rectum and the lower colon here.
Okay, all right. So in the setting of the rectum and colon and an area of ulceration and these polypoid masses, I'd be thinking the etiology could be that of inflammatory bowel disease. And something like ulcerative colitis or Crohn's disease would be the two main ones that come to mind.
So based on this image, what would you favour?
These could be pseudopolyps, and this could be a broad-based shallow ulcer, which would favour ulcerative colitis over Crohn's disease.
Yeah, and why? And what makes you favour that versus Crohn's? What's the key thing here that makes you go, oh, I think this is more likely ulcerative colitis?
Yep. So I guess ulcerative colitis is more of a submucosal or mucosal involvement as opposed to Crohn's, which is a transmural inflammatory process.
Yeah, beautiful. So if we have a look here, and I don't know if you can see my arrow, but down the bottom of the picture between the two needles that have been stuck into the specimen to pin it, you can actually see quite well the wall. I don't know if you can see my mouse outlining it here, but the wall itself here is not thickened. Okay, so that would favour this to be ulcerative colitis if you considered this to be inflammatory bowel disease. What would your differential be?
So other than inflammatory bowel disease, infective causes, so things like E. coli, there's a hemorrhagic type of E. coli, I think EHEC, and then Salmonella Shigella. And then ischemia possibly could lead to ulceration.
But wouldn't give you that pseudopolypoid formation, would it?
No.
No. Yeah. Any other infections you might think about? So you said E. coli.
E. coli, Salmonella, Shigella.
Yep. What about infections that cause pseudomembrane formation?
Oh, yep. So Clostridium difficile.
Yeah. I think that can sometimes be really hard to tell the difference on a specimen. But if you're going to talk about infection, which I think you're right to do, then I think it's also important to talk about those that cause pseudomembranes, which on a specimen can be quite difficult. On a picture of a specimen can be quite difficult to differentiate in that setting. Terrific. All right. So yes, this is ulcerative colitis. So off you go. Tell me about it.
So my understanding is ulcerative colitis is an idiopathic inflammatory bowel disease and characterized by rectal and colonic involvement, which helps separate it from Crohn's disease to a degree. Its epidemiology, I think, has a bimodal onset from memory, more often in the younger age groups, kind of teens to 30s, but also there's a second wave which can occur in kind of middle age and slightly older adults. And I think female and male were a similar proportion at risk. And smoking often get confused with one is protective and one increases risk. I think ulcerative colitis, smoking actually decreases risk. And I think with Crohn's disease, it increases your risk.
Mm-hmm. That's correct. Right. Good.
Associations would include things like primary sclerosing cholangitis and ankylosing spondylitis. Mm-hmm. It would kind of as associations, and then I think the major association, which might be more of a complication perhaps, would be colon cancer. That they are increased risk of colorectal adenocarcinoma. I think still they are at an increased risk, but that doesn't mean that they're definitely going to get it. I think only a small proportion end up getting it.
Do you know of any staging systems?
I think you can stage it by extent. Mm-hmm. So whether it just causes proctitis, whether it involves just the left side of the colon, or whether it is pancolitis, and the pancolitis I think has a greater risk of colon cancer. And you can also stage it clinically, I think, in a way that there are kind of presentations with the amount of stools per day and symptoms.
Yeah, so there's a Mayo score, which includes exactly what you talked about, and there's also an endoscopy way of staging severity. Terrific. So can you tell me about the morphology of UC?
So UC always involves the rectum and extends proximally with continuous involvement, and can even affect the terminal ileum, which is known as backwash ileitis. And the morphology, as kind of described earlier, was that this kind of limited to the mucosa and superficial submucosa.
Yep, and mural thickening and serosal involvement is not a feature. And can you tell me some of the clinical features? How might these patients present?
Yep, so they might present with abdominal pain of a wide variety of either an acute severe peritonism or kind of a subacute or grumbling ongoing abdominal pain. They may have diarrhea, which could also be bloody. They would probably be the main presenting presentations that we would see.
Yep, and complications?
So complications in the setting of UC can include perforation, toxic megacolon, which is seen in UC, and then
so you talked about cancer risk. So the cancer risk is really related to the duration, extent and severity of disease. So typically occurs at 8 to 10 years after the onset of the disease and correlates directly with how severe it is. And I think the cancer risk is of the order of like 0.5 to 1% per year after 10 years of the disease. So it's not an insubstantial risk. Depending on how severe the patient has it. And you talked about PSC as an association earlier. Do you know what the treatment is?
So I guess treatment ranges, I think, from either a non-surgical medical-based approach to effectively colectomy, entire removal of the colon. And so there's disease-modifying drugs that they can trial, and then, progressing to various surgical procedures as required.
Okay, great. All right. So you touched on some of the key differences between Crohn's disease and ulcerative colitis, and I think it's really important. This is actually a really important slide because it really underpins the differences between ulcerative colitis and Crohn's disease, and we can divide it up into macroscopic, microscopic, and clinical features. So in terms of the macroscopic features that distinguish the two disease entities, as you correctly identified, it's rectum. In UC, it's rectum going proximally to involve the colon, and if the ileum is involved, it's due to backwash ileitis, not because of ulcerative colitis that extends into the ileum. Whereas Crohn's disease can occur anywhere from mouth to anus and is typically, rather than this continuous distribution, is characterized by these skip lesions. Stricture formation is common within Crohn's disease, but rare within ulcerative colitis. And as alluded to in the description, as you correctly identified in the description, the wall is thin in ulcerative colitis, where it is thick in Crohn's disease, because underpinning the process in Crohn's disease is the fact that it's a transmural process versus ulcerative colitis, where it's just located within the mucosa and submucosa. So those are really key pathological features that distinguish the two entities. Pseudopolyp formation can be seen in both, but is more classically described in UC, and the ulcers are quite different. So whereas in ulcerative colitis you get those broad-based, like we saw in that specimen, those broad-based superficial ulcers, the ulcers in Crohn's tend to be deep and knife-like, and you get this sort of cobblestone appearance as a result. The fibrosis is marked within Crohn's disease, so that if you think about it, you can get stricture formation, which is a result of the fibrosis that we've just described, and granulomas, chronic inflammation, which we talked about earlier in this tutorial. It all comes back. It all makes sense. It all comes back. Granulomas are a feature of Crohn's disease, but are not a feature in ulcerative colitis. In terms of the clinical manifestations, so perianal fistulas are more commonly seen in Crohn's disease. Crohn's disease is more likely associated with fat and vitamin malabsorption. The malignant potential is present for both, but is more marked in the ulcerative colitis group. And recurrence after treatment is common in Crohn's disease. Toxic megacolon is more of a feature of ulcerative colitis. So thanks for that description, Matt. That was terrific. Who would like to talk to me about the extra-intestinal manifestations of inflammatory bowel disease?
It's Caitlin. I can do that.
All right, wonderful. Off you go.
So there are a number of subtypes of extraintestinal manifestations. Mm-hmm. So they can be broadly divided into gastrointestinal, which includes hepatobiliary and genitourinary, mm-hmm. And then musculoskeletal, ocular or orbital, cutaneous or skin-related, and then thoracic, so pulmonary and cardiac.
Wonderful.
So probably the most commonly talked about and clinically relevant are the gastrointestinal manifestations. So there are a number of hepatobiliary manifestations, which include PSC. So there's obviously a strong relationship with PSC and inflammatory bowel disease. So about up to 8% of people who have an IBD will have PSC, and within the PSC cohort, like 70 to 80% will have overt inflammatory bowel disease. Mm-hmm. So beyond that, there's also overlap between PSC, IBD, and autoimmune hepatitis. As complication of the PSC, you can have cholangiocarcinoma as well, for which PSC and IBD are risk factors. There's also gastrointestinal manifestations and other manifestations relating to the use of drugs to treat Crohn's disease. So in terms of gastrointestinal, there's drug-induced hepatitis, mm-hmm. Further moving into drug-induced pancreatitis, mm-hmm. And then there's also drug-induced, stepping into the other categories of change, there's also drug-induced cutaneous manifestations, pulmonary manifestations. An example of that would be sulfasalazine and eosinophilic pneumonia. And obviously then there are musculoskeletal complications and infective complications anywhere in the body. So obviously in the setting of use of steroids and the associated immunocompromise, abscess formation, whether that be associated with musculoskeletal system or the genitourinary system, for example, enteric or urinary tract fistulae, can be obviously associated with the immunocompromised state as well as the underlying bowel disease. In terms of genitourinary complications, nephrolithiasis, obstructive uropathy from scarring are probably the most common, as well as the fistulas that we've already talked about. And there's obviously a strong association with musculoskeletal abnormalities. So 30% of patients with an inflammatory bowel disease will have some sort of arthropathy. And in terms of specific manifestations, sacroiliitis is obviously the hallmark, classic presentation. But obviously there's an association as well with ankylosing spondylitis, osteoporosis, which can also be related not only to the malabsorption syndrome but to drug use. And then further complications like osteonecrosis, again with drug use, osteomyelitis and abscess formation. And then there's peripheral arthropathies as well. And then, on top of that, do you want more?
Yeah, no, that's great. No, that's terrific. So I guess the question then for the radiologist is, why is it important to know about these things?
So obviously, in terms of the holistic management of a patient, if you're reviewing any of their scans for any of the either primary or extra-intestinal manifestations of their inflammatory bowel disease, there are associated complications that it's important to be aware of and look out for. And they can have significant prognostic implications, and also, progressing from a strictly diagnostic perspective to an interventional and then procedural perspective, there may be implications for radiological procedures such as drainages of collections resulting from fistulas, etc., or sort of participation in an MDT setting with a surgical team trying to plan resections and noting complications.
Your music to my ears, Caitlin. That's wonderful. Thank you. So yes, absolutely. So the extra-intestinal manifestations, the reason the radiologist needs to know it is because we see it. And if we see it, if you don't look for it, then you'll miss it and you won't report it. So that's exactly right. And in assessing these patients, we do see all these things, and that's why it's important to have knowledge of them. So here you have, and I'll be honest and say I've adapted this table from a wonderful radiographics article which talks about the extra-intestinal manifestations of IBD. And so the key things, so this is a very long list and so it can be a little bit overwhelming, but we're going to step through it. And Caitlin's done a beautiful summary of this actually. But in truth, here are some key things that I'd like you to take home. The systems in green on this slide, so the musculoskeletal, the ocular and orbital, and the cutaneous manifestations of disease have a parallel to the degree of intestinal inflammation. So if you've got bad Crohn's or bad UC, then you will more likely present with these musculoskeletal, ocular or cutaneous manifestations. So that's number one. The ones that aren't in green don't have that same relationship of being parallel to the degree of disease severity. In terms of the gastrointestinal ones that I wanted to bring to your attention is PSC. So that's something that's important to look for because you'll see it on the corner of your MRE when you're doing your MR enterography. You'll see the liver and you'll be able to see the biliary tree. So you always must look for evidence of PSC. And of course, there's overlap between PSC and autoimmune hepatitis. And I think it can be very difficult for radiologists to make the distinction, but it's something to keep in the back of your mind. And as is always the case with PSC, you need to think about cholangiocarcinoma. So it's one of those things that whenever you are interpreting scans where there's the possibility of PSC, you must have a high index of suspicion for the presence of underlying cholangiocarcinoma. In terms of pancreatitis and cholelithiasis, so there are several mechanisms that have been described for explaining why patients have pancreatitis, and you can see them, and they can be actually clinically silent. So the patient may not necessarily present in the classic way with pancreatitis, but you can see the manifestations of the disease on the imaging. And of course, cholelithiasis and gallstones is something that you always need to be looking out for, because there is a strong association between the two, thought to be more strongly associated with Crohn's disease than UC, and I think it's related to the way that the various vitamins, etc., get absorbed by the body. In terms of the genitourinary manifestations, in the same way as we look for gallstones, you should be looking for renal stones, but also these patients have obstructive uropathy anyway due to fibrosis, particularly in the setting of Crohn's, particularly in that right kidney for some reason. I don't know why, but have a look out for that, because it's not uncommon to see it. And of course, the fistula formation is a very important thing that is important to diagnose, because it has implications. In terms of the musculoskeletal and cutaneous, I think it's really important to understand the arthropathy, which Caitlin beautifully described, which is the sacroileitis, which we can see on all of our imaging. And then the cutaneous manifestations, if you're going to say these words in the exam, be able to be prepared to describe them. That's all I'm going to say to you. Lots of people throw these words out and then actually can't, when you push a little bit and say, oh, so tell me what pyoderma gangrenosum is, they can't describe it. So if you're going to mention it, then you really should be in a position to have a little throwaway line as to how to describe those two cutaneous conditions. Okay, final case for tonight, guys. You've been wonderful. Now, who would like to describe this to me, please?
I'll have a go.
Okay, thank you, Python. Off you go.
Okay, so this is a macroscopic cut specimen of a solid organ with an adjacent tubular structure. I favour this to represent the testis with an attached spermatic cord. Mm-hmm. Within the testicular portion of the image, within the right side of the testis, there is a smooth, well-circumscribed, pale yellow lesion, which extends towards the margin of the testis, but does not extend through the tunica albuginea. And so I favour this to represent a primary or a lesion of a tumour of the testis, and given the homogeneous appearance, I favour a seminoma, but I would check with the patient's age and as well, given that seminomas are more common in sort of the 30 to 40-year-old age group.
Wonderful. So what am I going to ask you next?
We're going to go through the structure of how to about germ cell tumours.
But we'll do, before we do germ cell tumours and before we do the framework discussion, which you very correctly described, what is the obvious question the examiners are going to ask you?
I guess.
How do you classify? How are you going to classify those
classification
tumours? Classification of testicular tumours, right? So that's going to be the obvious, and it'll be the same for ovaries, right? So you get an ovarian lesion, you get a testicular lesion. You must know how to classify these tumours. And the reason to know it is not because you then ramble off the different types of subtypes. It's because understanding the classification helps you understand the clinical significance of the tumour. So have you got a classification system for me?
Yeah, so I guess with testicular tumours, very broadly they can be divided into primary or secondary. Within the primary testicular neoplasms, they can be further subdivided into germ cell tumours or non-germ cell tumours.
Good.
Sort of down the non-germ cell pathway, there are sex cord stromal tumours such as your Sertoli and Leydig tumours. Lymphomas can also be classified in that. And down your germ cell tumour pathway, you can divide it into seminomatous and non-seminomatous, which then can be further divided beyond that point.
Okay, beautiful. And so here we go. Here's one I prepared earlier. So can you tell me, within the germ cell tumour category, why do we make this distinction between seminomatous and non-seminomatous?
So I guess the big difference between the seminomatous and the non-seminomatous is kind of the behavior and how they present their treatment, and all those things affect it. And that's why dividing into those two groups is quite important.
Yeah. Okay. So what's the, in terms of seminomatous, what's the main, like, how would you describe this group of tumours in terms of their behaviour?
So the seminomatous tumours are more likely to metastasize via the lymphatic system, and they later on then hematogenous spread is where they go. They're more commonly more radiosensitive, and they usually present earlier as well, and metastasize later.
That's right. So they tend to be very local tumours, and 70% of them are at stage 1, and we'll talk about staging in a minute. But the seminomatous tend to have better prognosis, less likely to metastasize, and has implications for treatment. Non-seminomatous, by comparison, as a group, can you talk to me about that?
Yeah, so I guess going on sort of similar things, they tend to metastasize earlier, and more present at a more advanced stage. They tend to metastasize hematogenously, and are usually radio-resistant as opposed to the seminomas.
Beautiful. So this is the reason why you're learning these classifications. It's not that we want to torture you, and I'm not fussed about going down the detail of 50 different subtypes. It's really to understand that the reason for classification, particularly of the germ cell tumours, is this concept that seminomatous, local, early stage, better prognosis, radiosensitive, versus the non-seminomatous stage group, which are aggressive, later presentation, radioinsensitive, more commonly have hematogenous spread. That's the real key to understanding why we classify testicular tumours in the way that we do. The other thing to say is that we talk about these classifications as if the majority of patients present very clearly as a seminoma or very clearly as a yolk sac tumour. But in truth, there is a large proportion, and you can see on the slide there, 40% of testicular tumours are actually mixed. So although we have all these beautiful classifications, in reality, the pure forms only occur in just over the majority of cases, but there's a large proportion which have mixed tumours. So moving on for that discussion, so talking about germ cell tumours, what can you tell me about germ cell tumours?
So I guess with the definition, germ cell tumours are tumours that arise from the germ cells within the testis.
Beautiful.
In this particular instance, and they can be further subdivided, as we said earlier, into seminomatous or non-seminomatous germ cell tumours. The epidemiology for germ cell tumours really varies depending on the subtype. However, in general, it's males between the ages of about 15 to 30, and given we had a seminoma, that's sort of the 30 to 40-year-old age group. Risk factors for germ cell tumours can be divided into modifiable, non-modifiable. So non-modifiable risk factors include undescended testes. Both the side that's undescended and the contralateral side has an increased risk. Family history and some genetics as well, such as Klinefelter's, has a slightly increased risk. And hypospadias is also associated with an increased risk of testicular germ cell tumours as well. And on the modifiable end, I think it's predominantly sort of previous radiation to the area that can increase the risk in that in developing germ cell tumours. So pathogenesis-wise, I think the majority of germ cell tumours arise from, I think it's intratubular germ cell tumours that is thought to arise in utero, and it just kind of stays there until the person reaches puberty, and then continues on to develop. And with that, the presentation can be varied. So they can be asymptomatic, or they can present with a non-painful testicular lump, and very few present with pain. And the subtypes we've described previously as well.
So that we've got the subtypes there on that table here. So seminomatous versus non-seminomatous. That's right. So talk to me about the testicular carcinoma spread and how it's staged.
Yeah. So as we described sort of before, depending on whether it's seminomatous or not, will depend whether it goes lymphatic or hematogenous first. In terms of lymphatic spread, it spreads to the para-aortic nodes first, and then from there it spreads elsewhere to your mediastinal or supraclavicular lymph nodes. And hematogenous is predominantly to the lungs, but you can have spread to liver, brain, and bones as well.
Okay, and do you know what the staging?
So in terms of the staging, it can be classified into 3 stages. Essentially, stage 1 within the testis/epididymis spermatic cord area. Stage 2 is to the retroperitoneal lymph nodes below the diaphragm. And stage 3 is outside the retroperitoneal nodes, kind of solid organs or above the diaphragm as well.
Wonderful. All right. So we talked about the distinction between seminomatous and non-seminomatous germ cell tumours. Do you know anything about the biomarkers?
Yeah, so there are a few biomarkers associated with the different germ cell tumour types, and they're very useful to know because it's useful in sort of the workup for testicular masses, for staging tumour burden, as well as helping with response to treatment as well. Some of the main ones that I know are AFP, which I know can be elevated in yolk sac tumours and sometimes in embryonal tumours as well. HCG, which is elevated in choriocarcinomas and sometimes in seminomas. And LDH is the other one, which is more sort of, it helps with tumour burden in the seminoma subtype and helps in recurrence in the non-seminomatous germ cell tumour group.
Wonderful. That's terrific. Absolutely excellent. So yes. So in terms of, and as you'll see, I'm a big fan of tables. So in terms of understanding this, we're now looking at this group. So the seminomatous group in this table here, which can divide it into seminoma and spermatocytic seminoma. So seminoma is by far and away the more common type and the one that you really need to know. It occurs in 50% of germ cell tumours. It's this classic 30-year-old man with a slightly increased HCG. It's the description for what we just saw at the beginning of this section of this case with a homogeneous white bulky tumour. Most commonly, it's confined to the tunica albuginea. There doesn't tend to be necrosis, hemorrhage, or mucoid cysts. And you can get, there we go, there's that chronic inflammation thing again, granulomatous reactions. You can see some in seminomas. Spermatocytic seminomas are actually quite a distinct entity, and they're called seminomas, but they're not the same sorts of things. They tend to be an older age group. Although if you see a lump in a testicle in a man of age 60, say lymphoma more likely than spermatocytic seminoma, because that's more common. But it is the classic presentation. This is in the older man. It's a very slow growing tumour. It's soft pale grey. It's 10% bilateral. It has mucoid cysts as part of its presentation. And then here we have all of those non-seminomatous germ cell tumours, embryonal carcinoma, yolk sac tumour, choriocarcinoma, and teratoma. All of these are more aggressive, tend to present with later stage, hematogenously spread, but all of them are actually quite a fair bit less common than seminoma, as we've described previously. So I'll leave that there for you guys to have a look at. But really what the take-home messages about what I wanted you to understand from this was really this distinction between seminoma and non-seminomatous testicular tumours. The implications for staging and for treatment are important. So guys, thank you so much for your time tonight. I really appreciate that you spent the time with me going through these cases, and I hope you've all learnt something. I hope that you've all been inspired to study pathology with increased vigour and enthusiasm, and I hope that I've shown to you how important it is to underpin all of your radiological understanding. I'm really grateful to everyone participating tonight. I hope everyone keeps well and keeps safe, and thank you. Have a good night. Cheers.